please give us a minute to set up the days for Plenary Session 2. We'd like to begin with Plenary Session 2. This is on Health is Not Alone, connecting the dots for systematic health literacy, affordability, universal coverage, and value-based pricing. May I please invite on stage our guests for this particular session. This session will be moderated by Dr. Shabnam Singh, Principal Advisor, Health Policy at the Confederation of Indian Industry. And we have with us Mr. Krishnan Ramachandran, Chairman, CII Task Force on Health Insurance and CEO, Managing Director at Niva Buba Health Insurance. We have Mr. Rajiv Vasudevan, Chairman to the CII Task Force on Ayush, Chairman and Managing Director at Ayurveda Hospitals. And we will be joined shortly by Dr. Santosh Matthew, who's the Country Lead Public Policy and Finance at the Gates Foundation. I will hand it over to ma'am to please take it forward.
Thank you, Kanchita. It's always a tough act to follow when you have stellar people like Dr. N.K. Singh, Dr. Shetty, Shobna, and then to come up with a topic like this, right? So you might be wondering, what is it that we would like to speak of? If you notice the conversation that happened earlier, you get this feeling that health is not alone. As the delivery of healthcare world over has evolved, it has moved beyond the realm of doctors, nurses, and hospitals. They are core to the subject for sure, but it has moved beyond it. And if there was any other way of looking at it more firmly, COVID could not have taught us better. We literally, all of us in our homes, were running healthcare facilities. How many of you, by a show of hands, had invested in a pulse oximeter at home for yourself or your families? There you are, right? How many of you accessed your doctors either for an acute condition or a chronic condition with telemedicine? Could you show me your hands? Again, right? So health today has moved beyond the boundaries which were traditional, and thereby it throws us a question which each one of us need to ask: what is the health capital that we all hold? Who talks to you about health? What is it that you know about health? So you go back in time and you will get this feeling that, what did I know of how to eat, what to eat, or when to eat? It was a grandmother telling a mother, and subsequently it went around sage on a stage manner. Or you have a community or your family telling you everything about health. You absorbed it through that. But today, each one, as mentioned in the earlier session, 98% of Gen Z has a mobile phone. 98% of them, irrespective of socio-economic conditions. So they're carrying this piece, which to them is the window to health capital, right? But now the question to ask oneself is this the kind of health capital that we want to have? Or is it a different way of looking at this health capital? Do we need to structure it? Do we need to make sure the narrative is such that it empowers a person, A, to know when to ask the right question, to interpret what Krishnan in the earlier session said, that 25,000 crores of claims were settled by them, but how many people know about it, right? The cases of COVID care are coming up now. So at that point in time, everybody wanted a bed, everybody took the care that was given to them without questioning. Today they are questioning why didn't you give me remdesivir? Or why did you give me this? So this particular next half an hour, we have a stellar combination. Dr. Rajiv Vasudevan from Ayush, Krishnan, you've already been introduced to, and Dr. Santosh Matthew will say, I'm not a doctor, from the Bill and Melinda Gates Foundation. So the discussion that I would like to stimulate is, how do you see the value of health capital in the context of addressing the trust deficit and empowering, as Dr. Devi Shetty said, the most important person or persons, and that is patients, and that means citizenry at large. So I let Santosh have a sip of water. So, question to you. So how do you see this evolving, and how do you see it impacting the entire delivery aspect, both from an accessing perspective as well as from a utilization perspective, Santosh?
Thank you so much, and thank you to CII for this opportunity. I think what we really need is to stretch our imagination. So you can accuse me of talking in the next half a minute or so of things which has never been done before. The moment I say this, the first question I'm asked is, has it been done before? Where is the evidence? And I keep saying that, listen, if you want things that have been done before, don't come to me. So I'm going to try and put forth for your consideration an imagination that is today possible in India, and I would dare say nowhere else in the planet. And the reason is, coming out of COVID, we have learned a few lessons. The fact that we are today a very young country, the fact that 95 to 98% of our geographical area is today covered by mobile connectivity, the fact that we are on the threshold of interoperability and registries made possible by our Ayushman Bharat digital mission, the fact that today young, old, illiterate, literate, rich, poor, they are quite comfortable on using digital means as a way to plod through their daily existential issues. The fact that we have an IT system that has worked so marvelously, and a payment system which is like no other part of the world, is the opportunity before us. The problem with healthcare is that if the receiver or the seeker of healthcare, frankly, is not in the best position to judge whether they are getting appropriate care or not. The further you go on the knowledge spectrum, डॉक्टर साहब ने सुई नहीं दिलाया, ये कैसा डॉक्टर है, right? Or की use of steroids for instant relief. So unless you have a mediation between, so in economics this is called a credence. A credence good is where the person who is purchasing is not really the person best placed to come to a judgment on the quality of the good or service she is purchased. Therefore, in healthcare, you will necessarily have to have intermediation by experts. The problem today is that while it is possible, we do not, and structurally there is hope, we don't have the systems to make that happen. I will talk, and I'm sorry I was late because I had a meeting in Niti Aayog where I was advocating precisely this. And it's this, right? So we have continuing medical education for health professionals. That's based in the Western concept of you will do research based on which you will advocate a particular practice. But in India, we can now visualize a continuing medical education that is rooted in a sampling, a real-time sampling of prescription practices that's actually ongoing, provided your personal health record becomes ubiquitous. The National Health Authority has just announced a new policy on value-based care. They are saying that they will actually do a survey of inpatient care using the 5D5L network. framework, which is basically a health-related quality of life index. They're saying that on the basis of pre and post, if there is a delta which is significant, we will give the provider extra remuneration. So basically, it's an incentivization process. So if we can think of a system by which healthcare seekers don't go to a hospital, if people who are seeking primary care, including immunization, screening, family planning services, don't go to a facility, instead they actually approach it via their mobile phone, where the requirements are triaged, where the availability of experts, supplies, load on the particular hour, which basically means you need the observability on appointments, which place is more crowded. You can actually have a system in India today by which you can help people navigate the health system. A colleague of mine, 35 years old, suspected stroke, a close relative is a neurosurgeon, actually rings one of the foremost hospitals in Delhi, and I'm actually shepherding this person. I didn't shepherd initially, so he's taken there. So I asked him, how is he? I'm waiting in the queue. He said, I'm coming. The problem is, if you are a case of suspected stroke, the queue is not where you should be waiting. Now, this is a person who works as a colleague of mine, and this person is in Delhi. Think of the 75-year-old woman in Bastar who does not own a mobile phone, who is illiterate. Can we make it possible for her to be educated, to have services that today a 21st century can deliver? I believe it is possible if you have one point through which the ticketing is done, one point through which care coordination is engineered, one point through which you can actually help that person navigate the entire wellness and care continuum, is the imagination I would like to leave. I will stop here because it's an opening remark, and I will come to if there is more interest. Thank you, Shabnam.
Thank you, Sanju. So, what I hear you say is a reiteration of the fact that people have to know, and that knowing is going to come through the mobile device, and that is going to navigate. I'll turn to Krishnan here. Krishnan, in your opinion, this navigation of the how-to part has been laid out. The question, is this something that as a peer you ask yourself, right? And that is the filter at which I need to take care of myself, whether it is from a wellness perspective, right? Is that kind of capital present today in people? Is it something that we can grow on? And if so, how? Whose responsibility is it to be able to enable the individual to know the what of it, right? And then will be Santosh's point of the navigation of how they will do it.
Thank you, Shabnam. Thank you, CII, for having me. Just to pick a thought or a theme from what Mr. Matthew said before this, he referred to healthcare as being a credence good. And I guess as an insurer, the biggest challenge we face is, use different economic terms, is the whole information asymmetry problem, right? Health is an area where the doctor determines what's wrong with the patient. He sort of indicates what's the line of treatment, and he also determines how much treatment is needed. And if we have to move forward, as an industry, to your point, we do need these markers that establish credibility and therefore trust. So I just thought I should round that off from the point of view or the perspective of a health financier, because at the end of the day, we deal with public money, and when we settle a claim, we do have a fiduciary responsibility to make sure that we are able to assess what's being done is appropriate, not just from the point of view of line of treatment, but also what is appropriate from a cost standpoint. Otherwise, it just results in a vicious cycle of price increases. And going back to your point, Dr. Shabnam, on this whole question of human capital, if you will, I think there are two aspects to it. And the first one, I go back to what Dr. Singh said. Fact is, I think anywhere in the world, health insurance, private voluntary health insurance doesn't address more than 15, 20, 25% at most, of the population. So I think it's a myth to assume that health insurance is the panacea for solving access to healthcare, right? The public outlay part that he referred to is critical. And a middle income country like ours, ought to be looking at 7-8% of GDP in terms of healthcare spend. A large proportion of that, to your point, needs to go into primary and public health, to what you also said, Mr. Matthew. Because unless we solve for that, we go down this dangerous path of solving for acute care events in a hospital setting, which is just going to make healthcare increasingly unaffordable. So I think the first part is to increase public outlay and disproportionately a lot of it going into public health, which is a continuum of Ayushman Health, digital health centers is one example, but taking care of chronic condition is an altogether different ballgame than dealing with acute care events. Right? So I think that is one part of what we need to solve for, and I just go back to what I said, that fundamentally we need to figure out how we solve for healthier Indians. The second thing, the second aspect is again, taking off on what Mr. Matthew said, to the extent that, and of course, we do need secondary and tertiary care capabilities to address the percentage who are going to need that. I do think it needs to be done in a continuum of care, mechanism. And while the NHS is not a good example to quote these days because of the long wait times and queues, but I think that's the closest example I can think of to make sure that there is coordination and continuity of care. Because today, all too often in India, you end up in a hospital setting for stuff that needs to be taken care of outside of the hospital setting. And I think that telemedicine, to what Mr. Matthew said, has to play an important part if we have to solve for the paucity of healthcare professionals in our country. But really looking at this holistically, from starting with public health to the continuum of care, primary, secondary, and then tertiary. I think that's what we've got to figure out and solve for, as a health sector.
Thank you, Krishnan. I think you brought a very important point, that the continuum of care is an area which we as Indians typically don't look at. It's always an episodic intervention for an acute condition, and the rest of it is put at the back burner. I'll turn to you, Rajiv. India has a very, very proud legacy of traditional medicine, right? And if again I were to ask for a show of hands, that how many of you in the audience have at any point in your lives taken homeopathic medication, Ayurvedic massages, and Ayurveda medicine, right? So we are well endowed with all of that. Given what Krishnan said, and what Mr. Santosh Matthew said, that when you are going down to the last mile of connectivity, right, to the last person in a village, the legacy of traditional medicine is very, very well embedded. So when we are building this health capital, given the strong legacy, are there learnings there which we could adapt in a holistic manner to be able to address this? Over to you, Ram.
Thank you, Shabnam. And it's very interesting to take forward what earlier Santosh and then subsequently Krishnan said. So the term he used was credence, and trust was one of the key, believability and trust in the system. So I think we should first of all understand that this. Let's take another point which came in the totality of the challenges which is facing the sector. Dr. Devi Shetty in an earlier session talked about a 40 million surgery gap. 60 million people need surgery and only 20 million get it. So this is one thing which was told. So when you look at the nature of problems that are being initiated, you see that what are the solutions? And we still, to imagine that technology or Ayushman Bharat digital mission is going to solve it or some, rapid fix. We have solutions right in front where India can leverage, right? A country of 1.3 billion, and we probably doubled our population or maybe tripled our population in the last 70 years. But till then, we grew to this level as a Samriddha, very rich civilization. It is not the strength of some thing. So first thing is that before we get into other things, is not to reduce some other system of medicine to a massage, which is quite a travesty of the reality, right? So I think it's very important that we don't take that position and reduce it to Dadi Ke Nuske and villages. I think we need to go to contemporary Ayurveda, contemporary yoga, right? Till the same wisdom comes back from abroad, we Indians would look at it with a very patronizing attitude, which I think it's time we stop, starting now. Yeah? So that's one part. The other part I would say is that when you look at trust and credibility, a very important piece, continuum of care we spoke about. What is continuum of care? Let's take cesarean deliveries was a point which became as 40%. Today, with an increasingly urban population, shifting from villages to the urban poor is as much a reality as the urban rich as the rural poor. So, and the middle layer as we talked about it. If you take cesarean deliveries, we talk to gynecologists in any of the hospitals, the core issue is that 60% plus cesarean delivery rate, whereas in the US they have a 10 to 12% cesarean delivery rate. Why is this huge gap between the two? India as a poor nation going to that, and the fact is later pregnancies, a lot of comorbidities, gestational diabetes, all these things are leading to these issues. So from the patient, mother safety and the child safety, cesareans may be taken. So what is the role in ensuring that we begin early? The concept of health literacy, I think a point that you have you brought out earlier. If you take health literacy and starting with the young, I think this concept of, there was a vision that Dr. David Eagles, a well-known oncologist, he in 2012, in his well-known bestseller, wrote a concept called the end of illness, right? From cradle or from birth to death without illness, right? It's a very imaginary goal, so to say, but that is actually, if not completely realizable, but substantively realizable. How does that happen? Because if I understand the contributors to what constitutes health, right? So let's go back to trust and credibility. As opposed to episodic, emergency care, when I come in for a procedure, the narrative today has completely become an emergency room-led healthcare. Now, we talk about non-communicable disease for the last 20 years, I've been hearing the same thing. We need to tackle this, tackle that. Where is the solution? So we need to differentiate between symptomatic relief and root cause disease reversal. We need to differentiate between treating a problem and restoring positive health. Now, are we funding that which prevents that acute emergency? When I know that I have a chronic condition, it is going to necessarily, in most cases, evolve into an acute on chronic condition and then an emergency, right? I will just tell quickly one point here, that if you take diabetes, right? China is the diabetes capital of the world, India is number 2. And if you take a city like Bangalore, where I come from, out of an estimated population, this data is dated, because all data in India is dated. Out of a population of about 12 million, they estimate about 9 million at that time. They said about 85 lakhs are, or 0.85 million are pre-diabetics, and 75 lakhs or 0.75 million are 7.5 lakhs is diabetic. The question to be asked is, I know that if I'm already pre-diabetic and I take the latent diabetics, all of them almost certainly are going to become that, right? Where is my healthcare model intervening? And the moment in the US, as we talk to a healthcare insurance company, they are incentivizing people to not become diabetic because my insurance claim is going up 5x as opposed to non-diabetic. But in spite of such a scenario, today, what is my intervention? So today, so this is one part which I'm going in is effective interventions which are not necessarily hospital-based, which are empowering health management, which are also panchakarma, yoga-based, which will prevent this disease from progressing. The other important thing which is happening, which I don't know whether we are noticing, is whole person, which is typically to our hospitals. Incidentally, I come from Ayurveda Hospital, introduced as Ayush. I'm from a chain of private Ayurveda hospitals, and the bulk of the people who come to us, first of all, are in the 25 to 35 age group first. They're not elderly. Next is 35 to 45, 19 to 25. But the interesting part is that 25 to 45, if you take, typically people have 3 to 5 presenting issues. We got so used to a scenario that I just say, okay, diabetes ke liye ke paas jana hai. For your thyroid, go to somebody. Of course, they're endocrinologists. But take for your asthma, you go to somebody else. So low back, you go to this person. So I understand the need for specialization. But even with specialization, the need to look at a person as a whole person, one person, and then look at him in terms of what is the diet, the lifestyle, the mental health status, right? So we come to this paradigm of, do I have a whole person, systems thinking approach to health, which actually from an insurance angle brings in this, not a transactional relationship, but a life cycle health management. Can we fund life cycle health management where there's an incentivization for delivering outcomes? You talked about quality of life. How do we define quality of life? I think it's important quickly so that we don't reduce Ayurveda to, I'll just take 30 seconds and conclude. If you take Ayurveda, which is the mother system of medicine of the world, it defines well-being, not wellness, because wellness is very loose. That's why this word massage and spa comes in, which is really sad. Ayurveda had defined 600 BC, which WHO 1976 defined as a definition of good health, as the presence, not the absence of disease, the presence of good sleep, good appetite metabolism, good excretion, solid excretion, liquid excretion, right? And a pleasant state of mind, spiritual harmony, and finally clear sensory organs. Now this is the shloka, it says that, which is much in terms of physical, mental, spiritual, social health and all that, which 1976 WHO adopted. Ghar ki murgi dal barabar. This is the situation in India, right? All the wisdom which resides here, right, which is there. So if you take whole person, you take trustworthy care, I think we have a huge opportunity. And I want to go to the fag end. So we take primary prevention, primal prevention, which is working with expectant mothers. Ayurveda can really complement hormones. You take primary prevention beyond going into the typical executive health checkups, which we insist on, even for insurance companies and other people. How do we truly make our primary health centers work at a whole person level in the cities? Today, our primary healthcare system, which Government of India has also rolled out, right, is still predicated on 5 common diseases: cancer, heart disease, and a few like that, which is extremely limited in perspective. So we need to go beyond that. Third is chronic disease care, effective root cause care. Finally, post-acute emergency. Where are we funding beyond the 30 days domiciliary care? True stroke rehabilitation. You need a model where the average length of stay can be long, where it is still profitable as a healthcare delivery model, to deliver profitably for a private enterprise, whole person care, rehabilitation for stroke, cancer. If I show you some videos from some of the hospitals, and today what is happening with this is integrative. When we say integrative, it is not mixopathy, it is not Ayurveda and allopathy mixed together by one doctor. It is respective specialty. It is not. It is not a mixopathy. It is individual specialists delivering what they know best, but seamlessly in the best interest of the patient, depending on the patient's stage. So this is a model that works very beautifully and which I think will build trustworthiness, because overall cost will be brought down for the patient on a life cycle basis. Thank you.
So, with that passionate address of Rajiv, I think it exemplifies what our stand was, the need for health literacy. How many of us in this room have got our fundamentals cleared about this? Like the point he keeps making, it's not massage. Please do not equate it with it. It is integrative medicine, right? And so on and so forth. So, Mr. Matic, the last quick round, since we are running short of time. Given this context, in which, and I go back to my earlier point, that when I don't know, how do I ask? How do I seek? How do I know I'm getting the right thing? Which then addresses, can I afford it? Right?
I want to start by actually complimenting Rajiv ji for that excellent intervention you made. I also need to make a personal testimony here. So for years I suffered from something called high hemoglobin. I used to live in the mountains in Missouri. I was teaching at the IAS Academy for 6 years. So my hemoglobin actually went up, and when I came back into the plains in 2000, it never came down. So they suspected all sorts of things. And finally it was the Kottakkal Ayurveda in Kottakkal in Kerala, where they actually solved this problem by a combination of Ayurveda and yoga. And the thesis was very simple. And they have a PhD in yoga, so he approaches it not in terms of exercise. Actually, it's curative yoga. So their thesis, therapeutic, their thesis was that your hemoglobin is high because the oxygen concentration, your blood system is not able to provide. So you need to improve or restyle your breathing. And believe it or not, my hemoglobin was brought down to normal. So at one level, they were suspecting some kind of cancer. And at another level, you have holistic, which is not mixopathy. I'm so impressed by that particular word that you used. So I am a living testament to what you said just now, sir, and I thank you for that. The point I want to raise is that, and you rightly pointed out, today when you look at the digital health mission, or we look at the health and wellness center, we actually have to look at the government structures and also compartmentalize in our own brains. We have these systems of medicine actually, operating separately. So what's stopping us as Indians to actually integrate this? Because if it's critical care, if you're actually having a heart attack, I don't think there is much doubt as to what kind of care you need. But if you are presenting as a case of pre-diabetes, there also I think it's fairly clear as to what the care continuum by integrating our systems and what it should be. So I think what we really are looking for, and Shabnamji, the point that you raised about health education, it's more about educating our delivery systems to be able to respond to the care continuum requirements from a position of true scholarship, which is not massage for wellness and steroids for steroid for inflammation. Okay, let me put that. Steroids for inflammation. So that, and I would again, for everybody's kind consideration, I think it is entirely possible in the Ayushman Digital Health Mission construct. In fact, practically, if at scale we want to do it, the only way according to me to do that is to leverage the digital structures that we're putting in place so that we are able to integrate care from a delivery perspective. So if the choices that are being offered, either through insurance that is privately funded or the government systems, we need to produce the tools, the capacities, and the pathways through which proper advice can be given, and the friction and the navigation through these multiple systems. hospitals. Even now, if I have to go to Kottakkal, I actually need to ring up my, IAS colleagues in Kerala and say, listen, I need to get an appointment, kisi se baat to kar le. So we have to reduce that friction, which also could be a question of scale, could also be a question of where the investments will actually happen. We are therefore, as you rightly say, Rajiv, we are actually in a very interesting place where the possibilities from integration are enormous, but our mental models, leveraging 21st century opportunities, which I again reiterate, only India presents, we have not been able to produce the imagination that can see us through to be a productive nation with productive and well-being individuals. Thank you.
Thank you. So, last question to you.
If I may, I just want to comment, and I think it's been a fascinating discussion. Thank you, Rajiv and Santosh and Dr. Sharma. Look, in mathematics, there's this whole concept of local and global maxima, and I think the way our industries are organized today lends itself structurally to local maxima. I mean, if I look at healthcare, you have the hospital industry, you have the devices industry, you have the pharma industry, and even hospitals, you have different systems of delivery there. And at the end of the day, we're all economic actors. So we optimize locally for our ends. And as long as this is the case, I feel it's going to be quite difficult to deliver global maxima for the country. So, I mean, just to go back to what all of us have been saying, I almost think, and Dr. Shetty referred to this earlier, that I do think that there's a case to reimagine industry structure in economic terms. Because with the current structures being what they are, I do think it's quite difficult to actually deliver what is going to be a globally optimal outcome. Unless we redo the structure, reimagine the industry, we're all just going to be optimizing for ourselves and never optimizing for the whole system. I just thought I'd add that to the discussion that we've just had.
No, that's a brilliant point and a way to encapsulate what was said, Krishnan. So my question that I was asking was that can health insurance, the payer, be a facilitator in this piece? Somebody has to catalyze this.
I do think so, and maybe in two ways. One is when we become bigger and bigger, there's this whole concept of ecosystem orchestrator. Given that we control the money flows, I do believe that we can orchestrate how care delivery fundamentally happens. But for that, I think we are a few years away because we still don't have the scale. In the scheme of things, we are a 73,000 crore industry, but maybe 5 years out, when we are a 2.5 lakh crore industry, we could play the role of an ecosystem orchestrator that perforce engineers and forces a lot of the coordination, collaboration that we've discussed to happen. So that's one possibility. The other possibility is what Dr. Shetty referred to, and it's a model that's prevalent in some parts of the world with some success. In the company that I work in, Bupa, for example, runs integrated financing and care in several of their markets. So in Spain, in the UK, in Australia, these two work as a combined. The other model which works quite well but is not scaled beyond a few geographies is Kaiser Permanente, where they again solve the economic incentive problem by bringing together the money flows and care delivery under one umbrella. So I think it's in one of these two ways that health insurance could possibly play the role that we're looking for, Dr. Sharma.
Thank you, Krishnan. So the last question to Rajiv. Rajiv, what would you say is the one most critical lever to press now, today, so that we can actualize for tomorrow?
With respect?
With the change. Because the change of continuum of care, to catalyze the thing, we have to start somewhere. The first most critical lever in your mind.
I think we need to go beyond this definition of acute emergency care being funded, and in everybody's mind that healthcare is a life cycle by that, let me clarify. For example, a teenage girl, right, if she goes out to play in the sun, she's going to be saved from osteoporosis when she's in the post-menopause phase. Is something that people don't know. But today, most people who are in the know it is there. But I think that health should not be looked at on a momentary, event-based thing, but I look at it from a life cycle. The moment I look at life cycle, families coming together, behaviors at the dining table. So there is a lot of discussion going beyond this one narrative on how do I bring in more and more technology into healthcare. Technology has got a huge role to play in empowering individuals right down to the bottom of the pyramid, ensuring they are able to get data to make use of it in a way that the beneficiary gets it. So I think ADD and the way it is architected offers it's a vision for where all the stakeholders come together, where the patient holds the data. Having said that, if we use an old paradigm to run on top of a new age generation structure, we are bound to repeat what we see today. And I just want to conclude with this point. India has a great opportunity. Unlike the West, and we know the problems in the US and the UK, we see they have strengths and the weaknesses. But the point I would like to tell, India can learn from those mistakes, need not go this high cost, short length of stay, quaternary tertiary care model exclusively. That has got its place. But we've got to go before and after and ensure that there is an equitable, affordable model. And I think Ayurveda, yoga has got a huge role to play in that. Thank you.
Thank you so much. So we've got our answer. Please, a little louder, please. I know we are all hungry. So we've got the Sutradhara in place, and as said earlier, when in the opening remarks of the summit, the pearls are all there. So we are in a good place. Thank you so much for your listening, and thank you so much for the panelists.
Thank you, Dr. Shabnam Singh. Thank you to all our panelists.
I was told that we didn't have time. Any time for Q&A, or we can take it offline? Offline, please. Thank you.